Uh, Good morning. Today we will continue with the diseases of the inner ear. Anatomically, the inner ear is enclosed with the otic capsule of the petrous temporal bone, and it is composed of the cochlea, as we say in the lecture on the anatomy, anteriorly, vestibule posteriorly. The vestibule is made of the three semicircular canal, utricle and saccule. Diseases of the inner ear or labyrinth generally characterized by the sensory neural hearing impairment. This hearing impairment may be either recruiting, as I told you, the patient get annoyed by the a bit high sound in spite of the reduced sensitivity to the normal sound. Or we may get loss of discrimination. The patient hears the sound, but he can't discriminate. He can't understand the meaning of the sound. Or we may get combination of both. Secondly, the patient may go tinnitus. This is due to the affection of the organ of the corti in the cochlea or auditory portion of the eighth cranial nerve, cochlear nuclei at the brainstem on the auditory center at the Broca's area at the cerebral cortex of the temporal bone. Generally, this affection of the hearing impairment, whether it is recruiting or the loss of discrimination or tinnitus, is due to the affection of the whole perceptive neural pathway, starting from the cochlea to the auditory nerve to the cochlear nuclei to the brainstem, at the brainstem and the auditory center at the Broca's area of the cerebral cortex of the temporal lobe. Thirdly, we may get vertigo. This is due to the affection of the neuroepithelium of the ampullary crista of the three semicircular canal and utricular and saccular maculae. As I told you in the lecture on the physiology of the ear, the neuroepithelium of the three semicircular canal is the ampullary crista, and of the utricle and the saccule is the macule. Again, we may get due to the affection of the vestibular portion of the eighth cranial nerve, vestibular nuclei in the brainstem and their central connection. Inner ear disease in general may be either congenital, or it may be traumatic or inflammatory or vascular, or sometimes due to the ototoxicity and the aging process, what we call it the otosclerosis. Now regarding the congenital diseases of the inner ear, its causes may be either prenatal or it may be perinatal or postnatal. Regarding the prenatal causes, we have hereditary sensory neural hearing loss. This includes several syndromes. On top of the all is the Waardenburg syndromes. This is a six-linked dominant characterized by the shortened eye fissures, hypertrichosis of the eyebrows, which may be met in the midline, heterochromia iridis, different color iris, and white forelock. A portion of the hair will be white in center of the head. Secondly, we have the Usher syndrome, where we get retinitis pigmentosa. It is characterized by the progressive sensory neural hearing loss, progressive loss of vision, and we have Klippel-Feld syndrome, characterized by the short cervical vertebrae and the neck, sensory neural hearing loss, low hairline at the back, or sometimes we have Pendred syndrome. It is characterized by the goiter and the sensory neural hearing loss. Non-hereditary perinatal causes include viral infection, influenza, rubella, or glandular fever. We have perinatal causes. We have prematurity and anoxia, head compression during the delivery. Postnatal head injury. This may include mumps, measles, hemolytic newborn disease, ototoxic drug, or loud noise. Trauma to the inner ear. Commonly, any trauma to the base of the skull It may involve the inner ear. So we have the fracture of the base of the skull, which may be of two types. Longitudinal fracture, this occurs along the long axis of the petrous temporal bone, yani parallel to the long axis of the petrous temporal bone, involving the labyrinth. More common type, 80% of the injury to the skull base. It may have injury to the tympanic membrane, common with conductive hearing loss. Facial nerve injury is less common and of late onset. Transverse fracture, this forms nearly 20% of the fracture. A fracture line is at the right angle to the long axis of the petrous temporal bone, involving the labyrinth or the inner ear, causing severe vertigo, tinnitus, sensory neural hearing loss, with or without rupture of the tympanic membrane. Facial nerve palsy is more common and it is of the sudden onset. Treatment is that of the head injury in general, non-intraoral interference, systemic antibiotic to prevent infection, labyrinthine sedative for vertigo. Facial nerve injury may require surgery. Labyrinthine concussion is another type of the trauma to the inner ear. We get temporary reversible loss of the cochlear and the vestibular function. We have a disease, we call it Kaizen disease. It is a decompression disease. We get the inner ear trauma due to rapid decompression in diving and submarine works. We get bubbles of the nitrogen released suddenly as emboli and damages the organ of Corti. Now you consider acoustic trauma, which means trauma or injury to the inner ear or labyrinth by loud sound or noise. Generally, it may be of two types. We have acute and chronic type. Acute type is due to the blast or explosion of the sudden onset sound causing damage to the inner ear. Tympanic membrane may be affected or not. If the tympanic membrane remains intact, there may be a round window rupture with sudden deafness, vertigo, tinnitus. There is a severe high-frequency sensory neural hearing loss abruptly as a step drop of the bone and air conduction curve in the audiogram at the 4000 hertz, as it will be shown in the next slide. Degeneration markedly occurs near the basal turn of the cochlea, which serves the high frequency. As I told you in the lecture on the physiology, the basal turn serves the high frequency. As much as we go toward the apex of the cochlea, it serves the other frequency in reducing order. Chronic type, we have, we call it a noise-induced deafness due to the prolonged noise exposure, commonly happens in those working in the factory with a noise. We have, it is common in the boiler makers, welders, drillers, or those who are working in the airport by chronic exposure to the jet aircraft noise exposure. This causes cochlear damage at the organ of the cordi with gradual deafness and tinnitus. The hearing loss is not abrupt like the acute type. Again, we get a gradual loss of the hearing at the all frequency, and it reaches its maximum at the 4000 hertz. Treatment of this condition is by the avoidance of the noise exposure by using ear muff or the obturator. Surgery, sometime by tympanotomy, is indicated in the round window rupture for the closure by the temporalis fascia and gel foam. In the chronic case, the deafness is reversible in the early stage if the patient avoid the noise exposure. Vitamin complex B1, 6, and 12 may help to some extent in this reversing of the disease. You see in this slide shows us the acute type of the acoustic trauma. You see both the bone and the air conduction, it gets an abrupt step drop at the 4000 frequency. In contrast to the chronic type, we get gradual hearing loss gradual decreasing of the sound level pressure, and it will be maximum at the 4000 hertz. Now we consider the inflammation of the inner ear or labyrinthitis. Inner ear may get infected either from the meninges in the meningitis or by the blood-borne infection hematogenous route. This we call it infective labyrinthitis. Or it may be affected by the viral labyrinthitis following measles, mumps, or more commonly it may get infected from the middle ear. We call it otitic labyrinthitis. Degree of the involvement varies from the circumscribed localized perilabyrinthitis, يعني around the labyrinth infection, to diffuse or mild perilymphatic space inflammation, or to diffuse purulent infection of the peri and endolymphatic space to the dead ear. يعني we get 4 stages of the labyrinthitis. The first stage is perilabyrinthitis. We get affection around the labyrinth. Secondly, we get the circumscribed localized perilabyrinthitis. And thirdly, we get diffuse mild perilymphatic space inflammation to diffuse purulent infection of the peri and endolymphatic space. And the fourth stage, we get dead ear. So this is the 4th stage of the labyrinthitis. We may get the disease at any stage of these 4 stages. Clinical feature, we have otorrhea. Sudden vertigo as a main feature is associated with nausea, vomiting in severe cases. In the meningeal or the hematogenous type, the clinical feature may be masked by the meningeal symptoms. Nystagmus present, and fistula test is positive. Fistula test, we mean we apply pressure to the tragus or the external ear canal, alternate positive and negative pressure. The patient will get vertigo, or sometimes he may get nystagmus. Deafness varies according to the stage of the involvement. Initially mixed deafness may be, but later on we get severe sensory neural hearing loss. Treatment of the condition, we have to give antibiotic in high dose to control infection, labyrinthine sedative. We have to use cynarzine, stimetil, dramamine to control vertigo and vomiting. Hydrocortisone may be useful in some cases. Surgery to eradicate middle ear diseases and mastoid infection may be indicated in some cases if there is evidence of the chronic middle ear infection. Other diseases of the inner ears is presbyacusis, what is called senile sensory neural hearing loss. It means sensory neural hearing loss or impairment with increasing age, particularly after 60 years of life. It is commonest cause of the sensory neural hearing loss. It is a degenerative process usually affecting the organ of the corti, spiral ganglion or stria vascularis. It may start as early as 40 years or as late as 70 to 75 years of life. We get it of the several types. It may be either sensory, we get degenerative process at the organ of the corti in the cochlea, or it may be of neural type. We get the degenerative process in the neuron. The patient gets poor speech discrimination, or it may be metabolic type. We get atrophy of the stria vascularis, or we get the 4th type, we get impairment of the elasticity of the basilar membrane. Clinical feature, we get deafness of the perceptive type or the neural type with increasing loss for tones above the 1000 hertz. Speech discrimination is poor with recruitment. Commonly we get it in the sensory type. Treatment is hearing aid, helps to the certain extent. Tonic like vitamin B6 and 12 may help to some extent in geriatric age group. And now we have the ototoxicity and the ototoxic drugs. We have some drugs which are mainly toxic to the cochlea, causing deafness. We call these cochleotoxic drugs. Or we have some drugs which causes damage to the vestibule, which is the part concerned with the equilibrium, causing mainly vertigo. We call them vestibulotoxic drug. The onsets of the affection of the cochlea or the vestibule is of the slow onsets and reversible in the early stage with the most of the drugs when we stop the drugs, but it is irreversible in the later stage. Ototoxic drugs generally include aminoglycosides. We have the streptomycin, gentamicin, neomycin, kanamycin in common use. Some are cochleotoxic, other are vestibulotoxic, damaging the hair cells of the organ corti and the neuroepithelium of the ampullary cristae and utricular and saccular maculae. Stria vascularis also may be affected. Toxic effects are more likely to occur in those patients with impaired renal function because most of the drugs will be excreted across the kidney and the urinary tract. Second drugs affecting or second drugs which are ototoxic include diuretics. We have both the furosemide and ithacranic acids. They cause damage to the stria vascularis. Salicylates and the aspirin in the high doses, again, they may cause damage, causing deafness and tinnitus. They may be either vestibulotoxic or the cochleotoxic. Commonly, they are cochleotoxic. The fourth group of drugs, we have quinine and chloroquine. Tobacco and the alcohol also are the ototoxic factors or chemicals affecting the neuroepitheliums of both the vestibule and the cochlea. Treatment of this condition prophylactically to avoid the ototoxic or vestibulotoxic drug to stop using when the toxic effects appears. Secondly, curative, the offending drug should be discontinued at an early stage for recovery. Tobacco and the cool should be stopped. Vitamin B complex may be used orally or parenterally. Steroid may be useful in some cases. Other disease or the affection of the inner ear is sudden sensory neural hearing loss, by which we mean sudden, it is mostly unilateral decrease or impairment of the hearing by the nerve or perceptive conduction for at least 30 decibel and for 3 frequencies for 3 days. Its causes may be known or it may be unknown. It may be of the unknown causes or of unknown causes. Of the unknown causes, we have the vascular causes. Commonly, we have the vascular spasm, or we sometimes get intravascular agglutination, or we may be viral causes, influenza or other viral diseases. We may have a round or oval window rupture. Of the known causes, we have trauma, like blast trauma, acoustic trauma, windows rupture, we have decompression, or we have iatrogenic post-stapedectomy, or the cause of the known cause may be retrocochlear, where we may get meningitis, or we may get acoustic neuroma tumor of the eighth cranial nerve, or the cause may be central, like encephalitis, or we may get concussion. Clinical feature, commonly we have a history of the upper respiratory tract infection in 20% of the cases. As I told you, usually it is unilateral, sudden sensory neural hearing loss, occurs with or without vertigo, without vertigo or tinnitus. Treatment, we have a steroid in high doses, starting with 60 to 80 milligram prednisolone and gradually tapering over 10 to 14 days. We have vasodilator drugs like histamine or beta-histine hydrochloride. We may enforce to do surgery sometime for the closure of the window rupture by the fascia or the gel foam, or we can use hyperbaric oxygen therapy where we administrate pure oxygen over the face mask to the patient at a constant 2.2 atmospheric pressure for 90 minutes for every session, and we give the patient nearly 10 sessions. Now we consider the other symptoms of the inner ear disease, and that is the tinnitus. What we mean by tinnitus is the sensation of the hearing of the abnormal sound in the absence of any external noise. Its terminology comes from the Latin words tinnitere, which means to ring. The sound of the tinnitus may be either whistling, or maybe ringing, or hissing, roaring, boozing, or steam escaping type. It may be associated with deafness or without deafness. Generally, it is of the three main types. The first type we have is the objective tinnitus. This is a rare type. Sound is generated in the body itself, such as the turbulent blood flow, muscle contraction of the head, or the intratympanic muscle contraction sound. The sound is roaring, clicking, or steam escaping in type. Such tinnitus can often be heard by the observer, by the patient, but not only by the patient, by the one who is observing or examining the patient. It can be caused generally by the following pathology. First, we have vascular pathology. We have arteriovenous malformation. We have turbulent, hyperdynamic circulation, which we get it in the anemia or in the thyrotoxicosis or in the hypertension or pregnancy or fever. These five are the causes of the hyperdynamic circulation causing turbulent blood flow. Other vascular pathology where we may get objective tinnitus is in the glomus tumor or the vascular aneurysm. The tinnitus can be of the pulsatile or of the roaring type. The second cause of the objective tinnitus is temporomandibular joint disorder causing clicking sounds. The third is the middle ear muscle contraction, or what we call it the palatal myoclonus. The fourth is patent eustachian tube. Fifth may be pathological when we get a round window or window ruptures in general, round or oval window. The second type of the tinnitus is the subjective tinnitus. This means the perception of the meaningless extra sound. Often it is constant and varying in the intensity. Usually it is ringing or hissing or boozing type. It is most prevalent type. As we know, the objective was rare. It can be either benign sound, heard occasionally, or can be devastating. Roars can occur 24 hours, accompanied by the hyperacusis and distortion of the sounds affecting sleep and the work ability, leading to the depression or even sometimes suicidal tendency. Probable causes of the subjective tinnitus are pathological disturbances of the cell of the organ of the corti, like senile deafness, ototoxicity, noise trauma, or it may be physical distortion of the hair cells, as we get it in the endolymphatic hydrops, or it may be of the neural or the central disorder causes. We get S nerve tumor, disorder of the central connection of the nuclei of the hearing, or we get alteration of the sound conduction when we get it in the impacted wax, or otosclerosis, or secretory otitis media. These are the main types of the subjective tinnitus, or the main causes of the subjective tinnitus. The third type, we have auditory hallucination. This is generated in the cortical cortex of the central nervous system. Temporal tumor must be ruled out. It includes hearing, music, or voice sound. It occurs commonly in the psychiatric patient, those patients with schizophrenia, or sometimes you may get it in the post-operative if ketamine had been used, or we may get it in a drug abuse, like in the those who are using heroin or the other addictive drug. Now we consider the causes of the tinnitus, which may be in the external ear or in the middle ear or the inner ear or in the temporal mandibular joint or in the central nervous system. Of the external ear causes, we may have impacted wax, or sometimes we have the keratosis obturans. The middle ear causes, we may have otosclerosis, secretory otitis media, or the glomus tumor. When it is in the middle ear, we call it glomus tympanicum. Temporomandibular joint disorders, we may get a clicking sound mimicking the tinnitus. Inner ear diseases, we have menial disease, ototoxicity, noise-induced deafness, acoustic neuroma, labyrinthitis. Central nervous system diseases, either we have auditory nerve disease, brainstem lesion involving vestibular tract and the nuclei, or we may have aneurysm of the central blood vessels. Clinical feature of the tinnitus, it is usually unilateral, but it may be bilateral. Sound, as we told, may be hissing, roaring, whistling, or the boozing, or it may be of the pulsatile type, commonly in the vascular tumor. It may be mild to severe, occasionally heard only on the quiet places, or at night, may be constant or fluctuant. Sometimes may be irritative, causing disturbed sleep or work activity, and the patient may get depressed or may have even suicidal tendency. Finally, we have the treatments of the tinnitus. The treatment, either it be local treatment, general treatment, or we have the non-specific treatment. Of the local treatment, we have to treat according to the causes. Suppose it was the wax, we have to remove the wax. If it is otosclerosis or glomus tumor or acoustic neuroma, surgery is indicated. If Meniere's disease, it may be needs medical treatment, and etc. according to the cause. General treatment, we have to give the patient a long continued treatment with the labyrinthine sedative, namely sinarzine or beta-histine. Antihistamine may be useful, diuretics in the Meniere disease, anti-anxiety drug with the alprazolam, vitamin A and E, minerals like zinc, magnesium, and calcium may be helpful, anesthetic drugs like lidocaine or procaine. All these varieties of the drug indicate that there is no definite treatment for the tinnitus. Every case must be dealt with as on its merits. Some cases we can treat it, let us to say, to a great extent, and other cases, whatsoever you do for the patient still complaining from the tinnitus. Of the non-specific type, we have the hearing aids, digital hearing aids. It masks the tinnitus, or we have to use tinnitus masker devices like a sensitizer. We apply it with the headsets during the sleep to overcome or to mask the tinnitus. Or tinnitus relief with laser therapy had been introduced recently, and it is again of the doubtful value.